All right. Well, good morning, everybody. My name is Avina Trzynski. This is Millie Harford-Mills. We're from the Knowledge Centre. We're based at Edith Cowan University in Perth. And today we have some guest presenters from our collaborating partner, the National Centre for Education, Training and Addictions. That's the NCETA for short. So before we begin today, I would like to acknowledge the traditional custodians of the land that we are on, the Whadjuk people, and pay our respects to elders past and present. So thank you for joining today's webinar, and hopefully you're all getting some sound and you can see us. Please type in the chat box if you're having any problems, and we will try and help you during the presentation today. So before we start the presentation, I would like to introduce our guest presenters. Firstly, Professor Anne Roche and Mr. Alan Triffanoff from NCETA. For Anne, she is a professor and the director at NCETA. She has over 25 years' experience in the field of public health and has worked as a researcher, educator, policy analysis, and various public health sectors. And Alan is the deputy director of the programs at NCETA and responsible for identifying and developing and implementing a range of alcohol and other drug projects, and his associated activities have a law enforcement focus. The theme for today's webinar is what workers and organisations can do to support clients and communities in relation to crystal methamphetamine. We will have about 10 to 15 minutes at the end of the presentation for questions, so we ask that you save them till the end, and then you'll be able to type them in the chat box, and Anne and Alan will be able to answer them for you. So we're going to switch over now to Anne and Alan. And so what we'll do is Anne and Alan, we're giving you the thumbs up. So we'd like to see if you can get your sound on and that everyone can hear you. And welcome everybody. It's great to see so many people interested in this webinar today.
Hello everyone, welcome to this Australian Indigenous webinar. This is Anne Roche and Alan Triffanoff from the National Centre for Education and Training on Addiction.
Hello all.
And we're going to be focusing today on some specific issues related to crystal methamphetamine, and specifically looking at the role of workers and what organisations can do to support clients and communities. So the way, so we click. Yep. Good. We're just clicking our slides over for you now. So the focus for today's session has been driven very much because we know that there is a range of concerns for people working in alcohol and drug related, and also a range of generic health services. Certainly people are seeing an increased level of demand on their organisations and their workers, and are keen to find out better ways to cope with that demand and address the needs of their clients. And we know that there's increasing concern about clients who might be presenting with some fairly challenging behaviours, so maybe erratic and unpredictable sorts of behaviours. We've been doing work with services themselves, helping them to rethink the type of approach that they take to dealing with crystal methamphetamine problems and clients who may have those sorts of problems, and there's a range of things that services can do in that regard. We're also wanting to focus on issues about looking after workers, dealing with these challenging issues, and worker safety in particular. And finally, we want to focus very briefly on issues in relation to families and what can be done to support families, and particularly where it can be very disruptive for families where there's maybe an adult child, or there might be concern about young children and their well-being as well, and looking at how we can support them overall. So this presentation has been broken down into two parts. Click on. Yeah. So we thought we'd start by just giving a relatively brief overview about methamphetamine and running through some of, making it really clear about how crystal methamphetamine is differentiated from other forms of methamphetamine, so briefly some of the effects and patterns and prevalence, and just touching briefly on patterns and prevalence as it applies to Indigenous populations and Aboriginal populations, and then briefly about some treatment issues. Then we'll move on, and I'll pass over to Alan at that stage to focus on part 2 of the presentation, which will be the core of this webinar, and that's looking at a range of things about service reorientation and tailoring those kinds of environments so that we can better help and support people with problems around crystal methamphetamine, what might be involved with effectively communicating with clients and also families, the range of harm reduction strategies that can be employed, and we think that's quite important. Sometimes that gets a little bit overlooked. Helping workers stay safe and preventing and also managing some critical incidents that might arise from time to time, and again working with families and looking at worker wellbeing. So that's the structure of the webinar presentation for today. So if I start off then with that, just taking that step back and that brief overview, it's really important to understand that when we're looking at crystal methamphetamine, it really is one form of methamphetamine, and so previously people had been primarily taking speed, which is the powdered form of methamphetamine, and essentially what you have is various stages of processing, and the more processed the product is, moving from the sticky base product to powder to crystal, the more concentrated the psychoactive components are. So you might have 30 or 40% of the psychoactive proportion in your speed, but up to maybe 80 or even 90% in the crystalline form of it. So where people had previously been mainly taking speed in tablet form, it's a bit like switching from low alcohol beer to using a high concentrated spirit if you then switch to crystal methamphetamine, as people have been doing. Same product, but much more highly concentrated, much more potent, with much more negative potential consequences as a result. Okay, so just briefly recapping some of the effects of crystal methamphetamine, and hold this thought in mind. It's quite important in terms of prevention and early intervention strategies. The initial use of crystal methamphetamine is associated with extremely high levels of euphoria, with these massive levels of dopamine that get released in the brain. So it makes people feel terrific. So it's a highly attractive, seductive drug. It gives people a higher level of alertness and energy and a fantastic mood. So it's a really enticing drug for people to use. But we know it's also got a really substantial sting in the tail and some very, very negative downsides, and can have really dire consequences, and people can get into difficulty very quickly with the use of crystal methamphetamine, where they might have managed their use of speed much more safely previously. And the users will say they get into difficulty very, very quickly. It's helpful to think in terms of what happens in the early stages of the use of crystal methamphetamine, and where there might be opportunities for early intervention, and particularly say in a primary care setting and general practice. The sorts of early problems that are likely to be identified are kind of innocuous things around sleeplessness and disturbed sleeping patterns. And if people have been using on the weekend and going to work or school or whatever, university during the week, they might not have eaten very much or drunk very much water while they've been using, in a heightened state of stimulation over the weekend. Anybody who's not had a lot of sleep and hasn't eaten or drunk much is not going to be functioning very well. So at an early intervention and a really good harm reduction set of strategies is to make sure people try and get sufficient sleep and make sure they eat and get hydrated. Before you can have any kind of meaningful interaction with people, you really need to stabilize those components of their functioning. Crucially important, but often overlooked. We also know that there's often substantial cognitive damage that's associated with the use of crystal methamphetamine, and largely it's because of the release of dopamine and the impact that it then has on the reuptake system in the brain. So the brain doesn't self-regulate very well at all, and so people end up with problems in relation to poor memory, poor concentration, and a massive issue that can emerge for many people around emotional regulation and regulating their moods. So they become very difficult to interact with, and quite erratic and quite different to the kind of people that they had been previously. In some instances that becomes more severe, that they become much more reactive to any kind of stimuli and any kind of interactions. They can become quite paranoid, and agitation is quite common. From a mental health perspective, again, the common forms of presentation that you're likely to see are anxiety and particularly depression, because it's the obverse of what happens with the use of a stimulant, where people feel really high and terrific. When they stop using the drug and go into withdrawal from it, people will feel very low and very depressed, so very moody and very down. For people who use a lot on a long-term basis, that can become a chronic and severe problem. That's much more common, and that needs to be addressed much more frequently than concern that we often see depicted for us around psychosis. Whilst that can occur, and a transient psychosis is not uncommon, the much more common thing that you're likely to experience is anxiety and depression. So very important to think in terms of best ways to be screening and identifying and then managing anxiety and depression amongst this group of users. Okay. So we've become very concerned over the last few years about what's happening around crystal methamphetamine, and when we looked at patterns of utilisation and service utilisation and data on prevalence of use, we've seen massive increases in service utilisation. We don't know that there's a massive number of users who have started to use ice. Certainly previous speed users, we know most of them have switched over to using ice, and there's certainly indication from our wastewater data analysis that the amount of methamphetamine in our wastewater has certainly increased. So there's all sorts of indicators, including seizure data, that the problem is trending upward and not stabilising at this stage. And so what we've seen is that price has gone down, purity has certainly massively increased with the use of ice. That shift from using speed to ice is the one that's particularly concerning for us because of its high potency. And most ice tends to get smoked, be used by smoking rather than tablet form. And tablets allowed users to self-regulate much more easily. If you took a tablet, you knew that you'd taken one or half a tablet, you weren't going to take another one maybe for another hour or two, if at all. However, if you're smoking, it's much, much easier for people to continue to smoke and take more of the drug than was originally intended. So ingesting more of a higher potency substance creates more difficulty. So we know that there's a higher level of frequency of use. And we also know that most crystal methamphetamine is now being imported from overseas. So interdiction efforts have to now change because their policing strategies for dealing with local production probably not so relevant. So for many different workforces, there's a whole range of things that we're needing to look at quite differently and do quite differently. If we think then about the continuum of use, again, it's really important for us to understand that there is a continuum of level of use and severity of problems. The vast majority of people who are using crystal methamphetamine, if you have a look at this continuum that's shown here, use less than once a month. So 60% or so, more than half of people who report that they've been using it, do not use more than once a month. And that's important because they're not likely to be dependent. If you look at the other end of the continuum, it's around maybe 15 or 20% of people who report using crystal methamphetamine in the last month who have used once a week or more than once a week. And that's the group that are likely to be dependent and experiencing potentially very severe problems. An extremely important and very specialised treatment is probably indicated for that group. However, the vast majority of people who are using crystal methamphetamine are not at that end of the continuum. They're at that less frequent end of the continuum, but that doesn't mean that they won't necessarily experience problems. They may well indeed, but the kind of problems that they're likely to experience will be around those early stage problems of disrupted sleep, initial mood disruption, anxiety and depression, and there's a range of secondary prevention strategies that we should all be thinking about to try and give support to those people. They're likely to be employed in stable relationships and functioning pretty well as general members of the community and society. But we do know that people can rapidly progress from being at that low level of use to a higher level of use and a greater severity of problems. But it's important for us to think in terms of what we can do for early intervention and secondary prevention at that early stage before people start to move on to that sort of essentially that next stage. But once people got to a point of using more regularly around monthly, we certainly are going to see the presentation of a range of additional problems that we see there, and they are very important candidates there for brief intervention and likely to be quite receptive to that. So think in terms of that broad continuum of use, not only at that sharp, pointy end of the continuum where really severe problems have developed amongst frequent users. People always start out at the lower end of the continuum first, and there's plenty of opportunity for us to intervene effectively and give lots of support and very helpful advice to those individuals. If we think in terms specifically of Aboriginal people, we know that the prevalence of use is higher amongst Aboriginal communities, so up to around 1.6 times more likely to use than non-Aboriginal people. And we also know that where the data has been looked at over the last 12 months, it's national prevalence level for the population overall is around 2%, but it's around 5% for the Aboriginal population, and lifetime use again is around double that. Important jurisdictional differences across Australia. So, for instance, we know prevalence overall in Western Australia is particularly high. So, where there's also high concentrations of Aboriginal populations there, you have a baseline level that's higher to start with, so we would expect higher levels of use in jurisdictions like Western Australia and a number of other places as well. So keeping in mind that there are important regional and jurisdictional differences that occur. Our own work also found that amongst rural populations, it was about 50% to double the level of prevalence in rural population than metropolitan populations. It's a little bit unclear whether that's likely to be at the same high level of dependent use or whether it's just the lower level of more infrequent use. We're not sure about that yet, but certainly being very vigilant in the rural population and kicking in as many of those early interventions and secondary prevention strategies as possible is really important there. But we do know with Aboriginal populations, level of prevalence is the opposite. It's higher amongst metropolitan Aboriginal populations. So tailoring our service responses in that way is quite important. So just to recap on that, so if we think about patterns and prevalence, most users are not dependent. So we need to have a broad and flexible array of responses for people who are using and not think only in terms of the dependent user, as crucially important as that is. If we think also in terms of Aboriginal users of crystal methamphetamine, what we know is that they're presenting to our specialised treatment services at a much younger age. So we think initiation is occurring at a younger age as well. So thinking in terms of primary prevention strategies for quite young groups for the Aboriginal populations, and maybe tailoring some of our services to really cater for the needs of teenage users more than we've done previously, where the bulk of our treatment populations tend to kick off in their 20s. So, focusing also, just as an aside, some of the other concerns that we have about some of the risk-taking behaviours associated with crystal methamphetamine, because it affects judgment so very badly that we often know that people engage in risky behaviours that they wouldn't engage in otherwise, and some of those are associated with some risky sexual behaviours, and we're very concerned about the increase of sexually transmitted diseases across the population generally, but it's quite elevated amongst people who are using crystal methamphetamine, so that's just another indicator for us. Turning briefly to think in terms of treatment, we really want to dispel the myth that there are no good treatment options out there. It's simply not the case. Treatment does work in this area, and we also know that relapse is very high amongst people who've got severe problems, and there can be real delays in getting into treatment. We're encouraging the building up as much as we possibly can of greater treatment services and options. But our treatment options range through from things like harm reduction, touching on some of the things that we've already outlined, great scope for some really important harm reduction work and peer education work, great scope for early and brief intervention using well-established motivational interview strategies that we know are very successful. And some of those can occur in the primary healthcare setting, as I've mentioned. And for that sharper end of the continuum of use, certainly amongst the specialist AOD treatment options, very good evidence to indicate that cognitive behaviour therapy works very effectively with crystal methamphetamine users, albeit with higher rates of relapse, and so proactive follow-up becomes extremely important. But there's a range of other treatments that work very well, and so we do have effective treatments that we need to utilise. The established treatment regimes that we've got work very well, and the studies have demonstrated good efficacy with these groups. Post-treatment follow-up, again, though, is absolutely crucial, as is the engagement of family support and community involvement. Our one area that we're lacking, I suppose, from a treatment regime option is we don't have a gold standard in terms of pharmacotherapy, but that is not to suggest that there are no effective treatments available. There's a range of very effective treatments, so we have to utilise all of our treatment options because these really will be very helpful to both clients and their families. So just to recap that very brief overview, we need to keep in mind why people are attracted to using crystal methamphetamine. It is a particularly attractive drug, particularly for individuals who may not have a lot of life opportunities or other things in their lives that show promise and encouragement for them. So it is a very, very attractive and seductive drug, and we need to deal with that and tackle that, not ignore that. And most people, the thing to emphasise here, most people who are using are not dependent, but they still may get into substantial trouble with their crystal methamphetamine use. Lapse and relapse is very common amongst dependent users, so the focus just on detox and withdrawal is simply just the beginning of any kind of process. If we think in terms of what kind of service response we need, it is longer term and more intensive, and Alan will talk through in more detail some of the ways that we can reorient and realign our services to provide the kind of intensive ongoing support that would be required, and not forgetting the needs of family and other support networks, because they're crucial in the work that we do now with crystal methamphetamine. So I'll pass you over to Alan now, and he'll talk through looking at specific ways to support clients and communities as we outlined at the outset.
Okay. Thanks, Anne, and welcome everyone, and I'm hoping that you're enjoying what you've heard and seen so far. The next part is moving on from the introductory information about what methamphetamine is and what it does to people, and also what's available for people in terms of the various supports and strategies. So we're going to look at what can be done to change the way in which services might tailor their programs or their interventions, looking at how some strategies on how you can communicate effectively, some examples of harm reduction strategies, what people can do to stay safe, and that's workers and people around them. And also strategies for working with and supporting families, and then what can be done to keep workers safe and well-being, improving well-being. So before we start, as Anne mentioned, there's a range of options for providing help and support to people who are using crystal methamphetamine, but sometimes the service environments aren't quite right. And part of that is due to a whole range of things. And what are some of the things that might stop particularly Aboriginal and Torres Strait Islander people from getting help? They might not see their crystal methamphetamine use as a problem. They might be trying to manage the problems themselves. There's a perception out there, an incorrect perception, as Anne quite rightly pointed out, that treatment is ineffective. It's not ineffective. It's effective, and there's a range of effective options that are available to people, and that probably needs to be communicated more appropriately than it has been done to date. They might also believe that services can't meet their needs or not culturally appropriate. There's a key issue also that people might not be attracted to services that have been set up primarily for other drug users. So services that have been set up for dealing with people who might have alcohol-related issues or who might be experiencing opioid-related issues might not think that the service will be able to help them with their stimulant problems, particularly around crystal methamphetamine. And importantly, people might feel stigmatised, and that's a key issue in terms of not only for Aboriginal and Torres Strait Islander people, but for key issue in terms of anyone that's experiencing alcohol and other drug issues. We know that stigma is a key reason why people might not get help. It can also impact negatively on workers. And you would have seen some of the media portrayals about people who use various drugs, including crystal methamphetamine, and the impact that that has on the user, their family, and the services that are trying to help them as well. So organisations need to be aware of the impact that stigma by association can have on their workers, and then look at trying to implement things that can help to address that. Things like stories of recovery and achievement, reinforcing the positive things, and also reinforcing the valuable role that workers play in this whole situation is really important, because it gives that sort of confidence and reinforces workers' competence as well at the same time. As Anne mentioned before, there are a number of things that impact on people who use crystal methamphetamine. One of those is the cognitive effects, the effects that it might have on a person's intellectual functioning, their brain capacity. And that might then result in people coming into your service, and those services might be a primary healthcare service, it might be an AOD specialist treatment service, it might be a mental health service. But people with cognitive impairment will display things like forgetting appointments. They may not be able to finish tasks that they're given. They might have difficulty in concentrating or paying attention. They might not consider the consequences of their action and then feel invincible and do things that they wouldn't normally do. So being impulsive or engaging in repetitive behaviour and repetitive problematic behaviour. And then also that might result in sudden outbursts and violent episodes. Rare, but also need to be aware that that can happen. So what can be done to change the way services respond to people who might be presenting with cognitive impairment? Key thing in all of that is to have shorter, more frequent appointments. Adopting a flexible format and approach, recognising that people will have trouble taking some information in. Assertive client follow-up and appointment reminders, and by assertive client follow-up I don't mean that you physically assault your clients, but assertive client follow-up could be a friendly SMS reminder to tell them that their appointment's due. I know whenever I have physio appointments I always get an SMS reminder the day before telling me that my appointment's due and to contact them if I'm not able to keep it. Really simple strategy but really effective. Repeating important information, continually reminding the people that you're dealing with the key facts or the key things that they need to be aware of. And supplementing that with visual and written material and instructions and giving them stuff that they can then take away and read for themselves later. Providing reminders and memory aids for homework is a really key thing as well. And then when they're in your service, reducing some of the environmental features that can distract clients. So, loud blaring music or really bright lights. And I know that sometimes in some environments it's impossible to change that, particularly in sort of public hospital settings, but there are ways in which you can actually reduce some of the things that might distract a client when you're dealing with them and help them to concentrate and focus on what you're saying. When someone presents to your service and they're going through withdrawal, there's some key things that can be done. Again, fairly simple things, the 3 Fs as we like to call it: food, fluids and 40 winks. Again, reiterating some of the points that Anne made earlier. People that might be using crystal methamphetamine might have not slept for a while. They might not have eaten properly. They might not have hydrated appropriately. So just even the basic things of the 3 Fs can actually help calm the person down. Being aware that the person might be impulsive, irritable, and also going through extreme mood swings. And in those situations, the key things to remember there are don't panic or react in a challenging manner. Keep the partners or family members or other key people that are involved with this person that you're dealing with informed of the withdrawal process and what to expect. And the withdrawal process is something that is important to bear in mind because it can vary from people to people, and but there are some key things that you can be mindful of in terms of what to advise people when they're experiencing that, and also the people closest to them. Also be aware of and respond to self-harming activities, and then prepare for and preempt relapse, because again, as Anne pointed out earlier, lapse and relapse is quite common, particularly through the withdrawal phase, and again, reassuring people that is going to happen is quite a positive thing and quite reassuring for them as well, knowing that. If someone's presenting to your service and they're intoxicated, then again, their judgment might be impaired. They may not see the situation the same way that you do. Key thing in all of that is to use calming, de-escalating strategies. People are more likely to respond to someone in a positive way if they see that person as not being aggressive, threatening or confrontational to them. One of the key things is to use the person's name if you know it and try to establish that rapport. Again, provide, reiterating what I'd said before, provide comfortable seating and an uncluttered environment. And also, one of the key things is avoid furnishings that can be used as a weapon, things that can be picked up or thrown. So if you're interviewing someone, interview them in a room where there's minimal furnishings, minimal things that they can use to respond to you in an aggravated way if that is likely to happen. So what we wanted to sort of highlight though is that most workers have good generic communication skills, and it's that point about reiterating that what you're already doing works and what you're doing is effective, and you've already got quite a lot of skills and capabilities that you can use. But in saying that, it's also important to bear in mind that someone that's presenting that's been using crystal methamphetamine can be quite challenging, and being aware of that. So the key principles in terms of effective communication strategies is 1, stay calm at all times, maintain a peaceful environment, reduce the chances that the person will become angry or hostile, and then promote a positive, helpful interaction. And some of the ways in which you can do that is to keep your voice low and controlled. That even modulation, that even tone really helps calm down the situation. Use short sentences. Don't go into long-winded things that people will get confused about. That will only make them angry and agitated further. Repeat things, even though you might think, oh, if I keep repeating it, they're going to get angry with me. Not necessarily. Repeating, as we said before, if they're experiencing some cognitive dysfunction, then repetitive statements, repeating things can actually help the person take in what you're saying and might make sense for them. And also seek clarification. Ask them if they understand what you're saying, if it's clear to them. Be calm at all times, non-judgmental, and adopt a respectful approach. Being respectful to somebody is really important in terms of making them feel calmer and making them feel as though you understand what they're going through as well. Because that's a key thing with crystal methamphetamine use, is people that are using think that no one else understands what they're going through. And importantly, avoiding direct eye contact, because that can then act as a spur as well. There's some basic harm reduction strategies, and again Anne alluded to this earlier, that can be used by anybody that presents to any service. Some basic advice about healthcare, how to maintain their health, how to stay safe, giving them some strategies about what to do in those situations, who to talk to, where to get further information from. Again, those 3 F's about the food, fluid, and the 40 winks. Also provide advice about not driving while affected by crystal methamphetamine. Primarily, that's a key issue these days with random roadside drug testing, and also that keeps them safe and other people safe as well. Not using in dangerous places such as near a busy road. Advice about safer use, so how to use without binging, the effects of mixing drugs or overdosing, and safer injection. Peer education is also important. Getting them in touch with peers is really a key thing to help the person through the process, and is a positive step forward for them and for you in terms of building that rapport as well. Looking at other harm reduction approaches such as needle and syringe programs, again recognising that majority of people who might be using crystal meth might be smoking, but certainly those that are injecting, about the safer injection practices, but also about where to get further advice and assistance. And brief interventions. And what we like to say with that is that 5 minutes of time can actually make a whole world of difference to somebody who's experiencing issues related to their crystal methamphetamine use. It's a proven effective approach. Staying safe. And staying safe is a key thing, not only for the person themselves, but also for people who are dealing with them. So workers, organisations, families, other people. Some people will become agitated, but bearing in mind that most people who use are not generally aggressive. And so making sure that worker wellbeing and safety is the priority. And then if a person does become agitated and aggressive, being aware that responding to that is pretty much the same as you would respond to any critical incident. The key thing there is de-escalation. And so some of the key things that you can do to de-escalate a situation is to acknowledge any grievances, be willing to help, again asking the open-ended questions, reiterating that point about avoiding direct eye contact, which can be perceived as threatening, show concern through verbal and non-verbal responses, negotiate realistic options. Sometimes the person might be expecting certain things, be realistic with what they can actually achieve, what can be achieved in the short term and the long term. If your organisation has a safe room or a quiet room, take the person there, but make sure you've got a safe exit. And then ultimately reassure them that the uncomfortable feelings will pass eventually. If de-escalation doesn't work, then implement your own organisation's policies and procedures. That might include calling security or police if needed. And if you do have to call the police, make sure that all workers and bystanders or any other people that are in the area leave and don't re-enter until the police arrive. Also prepare everyone that's involved that the sight of a police or a security uniform might escalate the situation, and be aware of what needs to happen if that occurs. When you're working with families, it's important to listen and reassure them. Families are key to this whole process. They are going through a whole range of emotions and uncertainty about what to do and how to deal with the situation. So listening and reassuring them is really important. Providing them with relevant, specific and targeted information about what the drug is, what its effects are, what crash is, what withdrawal looks like, how it can affect the person's mood, their concentration, their decision making, and then if they ultimately leads to dependence and psychosis, what can be done to alleviate those things as well. Lapse and relapse is really key. As we said earlier, it's common, and reassuring families in particular that will happen is, I think, a key strategy in terms of helping them cope, but also in terms of establishing that ongoing relationship with them as well. Looking at what the range of treatment options are and explaining those to them and telling them that treatment does work and treatment is effective, but also being realistic about what's available. Examples of harm reduction and early intervention strategies, providing those to families is really helpful to them as well, can help them understand the situation better, and help them work their way through and relate to the person. Helping families to make a safety plan and reinforcing communication strategies if violence and safety is an issue. Helping them to make a safety plan is important for both them and the person involved. And I can't stress that point enough. I think that's a really useful thing to bear in mind. Workers are at the forefront, and they need to be supported. And so what are some of the ways in which they can be supported in responding to people who are dealing with not only crystal methamphetamine, but dealing with a whole range of issues that might be related to the person's crystal methamphetamine use? So things like encouraging, as I said earlier, encouraging workers to share stories about their work and especially their successes. Making worker wellbeing a priority. Key things like providing adequate debriefing after an incident's occurred, or even if it's not an incident, even after a particularly difficult or challenging session that you might have had with a client. Ensuring that they have quality supervision available to them as well. Professional peer support is really important. Being able to have networks of colleagues and co-workers that you can talk to, share stories with, share the information with, and share strategies with is really important. For workers working with Aboriginal and Torres Strait Islander people, for Aboriginal health workers, for non-Aboriginal workers working in Aboriginal services, recognising and utilising Indigenous ways of working, holistic approaches to health, commitment to community is key. The recognition of the role of family and community in the whole process is really central to that. Facilitating work with families and communities, reiterating, I can't stress that point enough. And then workers being able to support each other and look out for one another is a key worker wellbeing strategy. And it's something that we can do, all of us can do, every day. Okay, thanks for joining us again. So I just want to pick up from the webinar where unfortunately we had some technical issues at our end with the internet going down. So what I want to do is just finish off from the point at which we were cut off. So basically, I think we got up to the summary point, or the summary slide, and there are a number of points that I wanted to sort of go through again, revisiting some of the key things that we'd previously talked about. And the key one that I wanted to start off with is that workers are well skilled to respond to people using crystal methamphetamine, and just reiterating that fact too, that you know, people do have the skills, they do have the knowledge, they do have the toolkits available to them to be able to respond effectively. It's not always necessary to have to develop new skills or to even relearn the old skills, because what people are currently using and what they've got at their disposal does work. In saying that though, there may need to be, in some instances, a retailoring or reorienting of services and programs, and that's primarily due to the fact that some services may not have been set up to deal primarily with people who are using stimulants such as crystal methamphetamine. They may have been more set up to deal with people who might have been experiencing problems related to depressants such as alcohol or heroin. And so sometimes there might need to be a slight tweaking or a revisiting of what the protocols are. Key to any intervention is effective communication and using effective communication strategies. And that's really effective strategies that, particularly with crystal methamphetamine users, the sorts of things that are effective are things like very short, open-ended questions, short statements, reiterating key points to people, reflecting back on where they've been, where they're coming from, reinforcing and reassuring as well. Staying safe and staying calm at all times is a key strategy as well. Staying safe not only for yourself but for people around you and for also the person that you're dealing with. Applying harm reduction and early intervention strategies, and I'll when I go through the questions later on, there's some harm reduction strategies that I can actually fill some more details in about that are key things that are and that are proven to be effective as well. Working with and supporting families, and again one of the questions that I'll refer to later talks about that, and so we'll provide some more detail about that as well. And importantly, it's about supporting worker wellbeing, making sure that workers not only stay safe, but that their wellbeing, their both physical, mental, psychological functioning and wellbeing are supported and encouraged by their organisations, and that they look after themselves as well. And also enhancing their confidence that treatment actually works, and reinforcing that not only to themselves and their colleagues, but also to the clients that they're dealing with. So the key take-home message that I wanted to reiterate is that existing intervention strategies and treatment options work. There are treatment options available. There is no pharmacotherapy available at the moment, but there are a range of effective interventions that have been proven to work and that work well with people who are using crystal methamphetamine. Things like brief interventions, motivational interviewing, cognitive behaviour therapy are just some of the ones that we've previously mentioned in this presentation. So they are key things, and they're things that are currently available to people to use. Reinforcing the next point, which is around existing skills and knowledge, and that those skills and knowledge that people have are effective in supporting people who use crystal methamphetamine. One of the other things that is available, and this is a free plug for NCETA again, is our ICE training for frontline workers. It's an online training resource. It's probably the most comprehensive and free repository of information, training resources and materials on crystal methamphetamine that you can get anywhere. And I don't say that lightly. We know that people have provided us with feedback. That's one of the first things that they tell us. And we did spend a lot of time ensuring that we tried to include as much of the information that was already out there that people could access. We've also had quite a significant uptake, so there's been approximately 9,000 people who've registered for the online training since it was launched in January last year in 2016. Key thing to remember about the online training is that it's not only is it free, but it's adult-based learning. It's people can use it at their leisure. They can go back to it. There's no timelines. There's no requirements for completion. People can pick and choose the sorts of material that they want to access. If they do want to complete a complete module, they're able to do that, and they also get a certificate of completion at the end of that, which they can then go to their professional body and apply for continuing professional development points. Alternatively, if people are only interested in a particular issue that they want to focus on, then they can do that as well, and it allows them to do that readily. They can download materials, they can watch YouTube videos, and there's also exercises, there's reflections, there's things that they can then take away and talk to their supervisors about, and or managers, or their colleagues that they can share with as well. We also have a number of resources that are available, and these are all available for download from the NCETA website. We also have hard copies of them as well. The first one is the methamphetamine effects and responses. It's a 4-page flyer detailing in summary some of the key things that people might be experiencing when they're using crystal methamphetamine, and what some of the responses are that workers can use. The second one's methamphetamine use in Australia. It's an overview of the patterns and prevalence of methamphetamine use, using primarily National Drug Strategy Household Survey data. And then there's also one entitled ICE in the Workplace, looking at the impact of crystal methamphetamine on workplaces and what can be done to alleviate that. The other key resource that I wanted to highlight is the Feeling Deadly, Working Deadly resource, which is a resource that we developed a number of years ago now, but it's been probably one of the most popular resources that we've ever put together. It's designed to assist Aboriginal and Torres Strait Islander workers and people, non-Aboriginal workers working in Aboriginal services, and it's around strategies for maintaining their wellbeing. It includes a range of resources for workers, supervisors, managers. There's a checklist for ticking off the criteria for assessing your own wellbeing, your worker wellbeing. There are strategies that workers can use. There are strategies that supervisors can use to support their workforce as well. So with that, that's the end of our webinar presentation. Now, in view of the technical difficulties that we experienced last time, people did ask a few questions, and so given that we've now had the opportunity to look at those, I'm happy to go through that and provide some responses to those questions. So first off, Nikki asked, how does family support link to treatment and recovery? And one of the things again that I wanted to sort of stress, and again I think one of the things that was probably about halfway through the presentation was about the importance of working with and supporting families. And key in all of that is that families are often a great source of support and encouragement for people who are using crystal methamphetamine. But one of the things that families find is that they don't always know who to turn to, where to turn to, and what is available. And so they often need education, support and practical assistance and guidance to help them understand a couple of things. One is the issues that the person might be experiencing, and what they can do to, well, there's three. So one is the issues that the person's experiencing, two, what they can do to help that particular person, and thirdly, what they can do to maintain their own well-being as well. And so working with families requires an understanding of the dynamics and involves being able to assess and build on that family strength and encouraging families and reinforcing that what they're doing is the right thing, identifying and then reducing some of the harms that they might be experiencing and the person might be experiencing, empowering them also to make positive changes, and then providing them with evidence-based information and support and helping them to build hope for recovery. And important in that is the issue that letting families know, but also letting the individual know that people do recover from crystal methamphetamine related problems and that there is hope at the end of the tunnel. And so it's not, while it might seem like there's a lot of things happening and there's not much hope and people are feeling quite uncertain and are despairing about what they can do next, there is that reinforcing to them that there is that hope is really important. It's also important to include the family members as part of any treatment plan for an individual client. But in saying that, there's also a need to respect the client's wish for privacy. And sometimes they may not want the family involved at that particular point in time, and being respectful of that and also informing the family of that as well. Alternatively, what you can do in those situations is get the family in touch with other support groups, such as one that comes to mind is the Family Drug Support Australia, and their website is www.fds.org.au, and they have proven to be quite a valuable support for families who are really struggling with what to do and how to do it, and it's designed to focus on the family rather than the individual. So in those situations, they're a really valuable resource and a valuable source of support and also information as well. It's also important to assist clients who've experienced family breakdown and help them to re-establish that contact if that's appropriate. But also, equally, it's important to help supportive families strengthen their relationship with that person that's using crystal methamphetamine. We, NCEDA, that is, has developed a family sensitive practice toolkit, which is available from our website, and you'll see that on screen there, which is www.nceda.flinders.edu.au. And what that does is it seeks to include family members as part of the treatment program for an individual, and also addressing multiple needs, but it also considers and responds to the different impacts that drug use has on each family member. And there are a couple of major sorts of things that it does or aims to do. One is that it helps the workers be more aware of the impact that crystal methamphetamine use is having on the families, and then to be able to relate that to the families. And it's also focusing the intervention on the family rather than just using the person, rather than just the person who's using the substance. So again, I'd recommend that resource to people if they're interested. So moving on, Michelle asked, are there tools available to assist GPs with brief intervention strategies that are eye specific? And before I sort of get into that, it's probably worth reiterating what brief interventions are and what they aim to do. So brief interventions aim to find out more about a person's crystal methamphetamine related problems. They are designed to motivate them to address their crystal methamphetamine use and also help them to work through the risks and reduce the risks associated with using crystal methamphetamine. It's very timely. In fact, we only got this in the post today, but there is a new resource that's just been released, and it's called, and I'll hold it up, Assist on Ice, and I'm getting a bit of a, sorry, I'll go this way, Assist on Ice. It's a, basically Assist is the, for those people that aren't aware, it's the alcohol, smoking and substance involvement screening test, and brief intervention for methamphetamine use. It's been developed by the University of Adelaide, and I'll get to the more detailed stuff in a minute about that, but it's designed to support primary healthcare professionals in a range of settings. It aims to identify current or potential problems among people who are using crystal methamphetamine and motivate them to change their behaviour. And as I said, it's developed by the University of Adelaide. In particular, it's the Drug and Alcohol Services South Australia WHO Collaborating Centre for Research in the Treatment of AOD Problems. Mouthful, I know, but the actual toolkit was authored by Jennifer Harlan and Dr. Robert Alai, whom a lot of people who've been in the alcohol or the drug area for a long time will know Robert. He's just recently retired from his position at DASA, but he brings a wealth of experience and knowledge, and I would highly recommend, as I hold this up again, Assist on Ice to people to get copies of it. You need to contact Jennifer Harland at Adelaide University, and her email address is jennifer.harland@adelaide.edu.au. It is the only tool that we're aware of that's currently available. As I said, we've only got it in the mail in the last day or so, so it's brand new, hot off the press. The next question that we got asked was by David, who asks, as someone with little experience of this drug, meaning crystal methamphetamine, could Anne and Alan elaborate on their point about safer use, especially about how to advise people to avoid binging, mixing drugs and overdose? There's quite a few things which I'll just briefly run through that might assist you, David, and other people who are watching this webinar. The key one, I guess, is about reiterating the message to people who are using about the importance of not mixing drugs. So, for example, not mixing stimulants with depressants, such as heroin and alcohol, and reinforcing the important point about combining drugs increases the risks of accident and overdose, and also increases the risk of overdose. Also, reinforcing to people who are using that they may not always know what they're using. They may not always be aware of what the purity of the drug is, or even what its contents are. And so just even knowing that, I think, is important for people, and to relay that sort of information to people is key message, and simple message as well, and an effective message. As a worker, being aware of the sorts of pre-existing health conditions that the person might have. So, for example, Do they have an existing heart condition or liver disease? And again, reinforcing to them that using drugs such as crystal methamphetamine will adversely impact on their pre-existing conditions and may increase the severity of those conditions as well. Important message, again, one that we mentioned throughout the webinar, was about the fact that if people are binging, so if they're using crystal methamphetamine for prolonged periods of time, there's a great likelihood that they'll be sleep deprived, so they won't be sleeping for long periods of time, and there are associated risks with that. And so sleep deprivation, again, can cause risks around accidents, can cause risks around accidents and injury, loss of consciousness at important times, so basically losing track of where you are and what you're doing, and key message there is about the fact that encouraging people to get sleep, providing advice about using less frequently as well. So people may not be willing to stop, but if you can advise them about using less frequently, that also has an important harm reduction approach, and means that they can reduce the likelihood of firstly binging, but also overdosing. Providing them advice about unsafe sex, and in particular about unsafe sex increases the risk of sexually transmitted diseases. So risks of injecting is another one as well. So information about where to access needle and syringe programs, and also the increased risk of bloodborne viruses from sharing injection equipment. Also, it's important to provide people with messages such as that there are treatments available and that treatment works, again reiterating that important message that I made earlier, and also providing them with information about brief interventions, what assessment is, what are some of the counselling and cognitive behavioural approaches that are available, what happens with withdrawal management, relapse prevention, and then relapse management as well. And finally, advice about using in safe environments and not driving while affected. And again, the concurrent issue of the risks associated with sleep deprivation, particularly if you're driving. The next question was from Danielle, who wanted to know that when implementing harm minimisation programs such as needle and exchange programs, she was aware that there are treatment guidelines provided at state level under an overarching national drug strategy, and she wanted to know whether there are any monitoring systems in place which address whether or not the programs are being run in the way they were intended, i.e. according to the guidelines. So from a needle and syringe program, yes, they're comprehensively monitored, and they're monitored in relation to the amount and the nature of the equipment that's distributed, but they're also monitored in relation to the regional availability, and that's regional availability of the drugs, the equipment that's being distributed, but also the availability of drugs that might be in a particular region, and they act as a bit of an early warning system for particularly health services and health providers, and also for the needle and syringe programs themselves. There are also grant reporting requirements, so services and programs that are funded by particular grants are required to report on outcomes and report on both their process and their outcomes. There are also specific evaluations of programs that are undertaken at various times, and for example, here in South Australia, the Woolshed program, which is a rehabilitation, residential rehabilitation facility in the Adelaide Hills, was evaluated a while ago, and there's also been some work done in New South Wales by, particularly by the network of alcohol and drug agencies, NADA, as well. And that also leads on to another important point that I was going to make, in that in relation to the non-government sector in particular, there's a range of quality control mechanisms in place. And so my advice to Danielle is that if she wants to know more about what's available, then she can contact us and we can provide some more information about each of those and where to get further information. The next question was from Mary Ann, who asked, can you please elaborate more on the issue of stigma for workers? And so what I'd like to do there is just to, again, start from the beginning and reiterate the point that, again, was made in one of the slides earlier on in the webinar, which was around that the issue of stigma that particularly drug users experience, and that stigma is real. And those that are using crystal methamphetamine are particularly highly stigmatised when it comes to media portrayals. That's a recent example of how they can be stigmatised. And they also experience stigma associated with just their drug use, the fact that they're using a particular drug or an illicit drug. And what this can do is it can have quite devastating effects on them. It can wear the people down, it can isolate them, it can contribute to low self-esteem and depression, and it can also result in a number of other negative effects, such as limiting their ability to be able to find work or hold down a job, participate in day-to-day activities, access relevant health and other services. So the sorts of things that we take for granted become equally or doubly or more difficult for people who are using illicit drugs, but in particular using crystal methamphetamine, for them to access those things that we take for granted. People who inject drugs can also be particularly vulnerable to adopting these sorts of negative stereotypes, and they may stop recognising when they're experiencing stigma and discrimination because it becomes normalised for them. And it's also almost accepted or expected or considered as legitimate or deserved behaviour. And deserved, I put that into quotation marks because it's not deserved, but they're made to feel as though that's what they deserve, I guess. And importantly, workers that are providing services to people who are using drugs, to their carers and families, can experience what's known as stigma by association, and that can have quite a range of negative effects as well on workers, where they could lose their self-esteem, they could experience psychological distress, and it can also act as an impediment to attracting and retaining workers. And there's also a thing called compassion fatigue, and if people are interested in that, again, INCITA has done quite a bit of work around worker wellbeing, and if you're interested in knowing more about that, contact us. But also go to our website and type in worker wellbeing, and there's again a number of resources around that are available for download. The final question is, do you see a role for mandatory treatment for people dependent on ICE? The first point I'd like to make about that is that there's currently limited scientific evidence that's evaluated mandatory drug treatment. And what available evidence there is suggests that it doesn't always result in positive or improved outcomes, and in some instances it may result in increased harm such as recidivism or risky drug using behaviours. There is a program called HOPE, which is the Hawaii Opportunity with Probation Enforcement program, which has been quite extensively evaluated, and that's showing positive outcomes in some instances. And it's an intensive supervision program. If people are interested in that, if they type in Hawaii Opportunity with Probation Enforcement on their browser, they should be able to access the available information about it. In looking at mandatory drug treatment, it's probably more important to focus on rather than mandatory treatment, it's more important to focus on crisis intervention and assertive intervention. And a lot of the time when calls are being made for mandatory treatment, it's coming primarily from families who are in crisis, who are at their wits' end. They're not sure what to do, and they think mandatory treatment might hold out some hope, or it might be the last resort that's available to them and the person that's using. However, what they're looking for is crisis intervention. They are wanting to know where they can go to get help, what they can do to get help, what's available, and what can be done now. And so again, that sort of crisis intervention, assertive intervention, is really important in helping families in particular deal with that issue. Focusing on things like motivational interviewing is a key thing as well, in terms of helping the person, helping promote behaviour change by helping clients to explore and resolve their ambivalence about their own drug use as well, and crystal methamphetamine use. Providing them with feedback, open-ended questions, affirming their strengths, their efforts to change, are really important things that can help the person change the way they're thinking about their drug use. But I guess the take-home message from all of that is that we need to ensure that there's a range of treatment options available. We know that there are, and we know that there are effective treatment options, but we also need to ensure that the treatment places are available to people seeking help, and not only to the people seeking help, but to their families, supporters and carers and significant others. On that note, I think that's it, and I'd like to thank everyone for joining us and for taking the time to ask us the questions. Thank you. And these are our contact details, which are now on screen. And I'd like to thank the Australian Indigenous Alcohol and the Drugs Knowledge Centre for this opportunity to share this information with you and to participate in this webinar. Thank you.